introduction. I'm Dr. Li. I'm a child psychiatrist actually working at LECOM. And a little bit more about myself. I think you can tell I'm an Asian. I came from China, and I had my medical school in China as well. I received my residency training at LECOM, and then I went to all the way the other side of America. I went to UCSD and completed my fellowship program in child adolescent psychiatry. And eating disorder has always been my interest. I have been to the eating disorder inpatient unit, partial programs, and have known a lot of wonderful medical specialists in this field. So this is something that I just really want to share with the public and see if you have any questions, you have more interest, feel free to reach me after the presentation. Okay? Let's see. So I actually have shifted my topic a little bit from talking all of the eating orders. Instead of talking all of them, I have been shift my topic to be more focusing on bulimia specifically, because I think that's probably something they don't really know a lot. So I will just walk through this whole presentation. You will know what I mean. What is the eating disorder? Maybe this is a question for all of you. I don't want you to read what I said on top of the slides. Maybe just on top of your mind, what do you think eating disorder is? I'm really curious about what your answer is. What do you think eating disorder is? Yes.
I think an eating disorder is when you don't eat food for nourishment. When I think of an eating disorder, I think of it when a person uses food not to just benefit the body nutritiously, but tries to solve another problem by eating or not eating food.
That's a very good point. I mean, it's something that connects between your brain and your physics. I mean, if you thinking about eating as a connection, it has two components. One is the physical behavior that you're eating. The other is the psychological effect through eating. So that's exactly what eating disorder is. It's not perfect concept, but it's really what it really means. Eating disorder is defined as a type of disordered eating. It can be anything like overeating or restrictive eating, but basically they have very negative effect on a person's physical and mental health. That's why we call it disorder, right? And it's not too far from us. A lot of people thinking that I don't think anyone had eating disorder. It's probably, never going to happen around me. Actually, it affects up to 5% of our population. And in United States, there are 20 million women and 10 million men that suffering from this disorder, at least once in their lifetime. So there are a few types of eating disorder. Of course, let's just go over really quick of each of the type. The first one is anorexia. This is the most it's not the most common one, but it's the most recognized one. Anorexia, where a person restricts their eating because intense fear of gaining weight. Okay, they use eating, restrictive eating, or over-exercise as a way of managing their fear. Bulimia is another type of eating disorder where a person eats a large quantity of food and later try to get rid of the food through compensatory behaviors such as purging, okay? And the binge eating disorder is the most common type. So you probably have been seeing this a little bit more among people around you, where a person eats a large amount of food in a very short period of time, typically when they are not hungry, okay? The fourth one is called avoid restrictive food intake disorder. Basically, it says a person reduce or selectively choose their food choice because a psychological reason, not a physiological reason, okay? Pica, I think this is pretty common. A lot of new mom or, to-be mom or, to-be grandma already know that some children, they prefer non-food items. They eat paper, ooze or something that on the ground. These are classified as type of eating disorder as well. So eating disorder is not just an adult disorder, okay? Rumination disorder, this is pretty rare, but where a person regurgitates undigested food or minimally digested food after they eat it, okay? So these are the most common eating disorder types. Most of the eating disorder, they develop in adolescence and young adulthood, rarely develop in later age. So I guess most of you, including myself, are pretty safe if we haven't developed an eating disorder at this time point. It's more common in women, but it can also occur to any ages, and it can also affect all genders, okay? So these two, bulimia and anorexia, I think people heard a lot about them. They are very similar. They're both eating disorders. They share a lot of similarities. For example, both disorders have distorted body image issues. They always think they are really fat, no matter how much they weigh. They also struggle with cycles of overeating and purging, and it can lead to serious medical conditions. The differences are also, very interesting when you look at them. Anorexia is better recognized because it's characterized by weight loss. It's easy to tell from appearance of a person. It's also easier to be recognized in clinic. So as soon as you see a person with anorexia, you know this it is. But it's hard to identify bulimia on the other side because most patients with bulimia, they can maintain a normal weight. And the purging, binging, all these behaviors are often done in secret. So this is why I want to focus more on bulimia today, because I think, not only because it's often go undetected, also because it can really cause long-term or permanent damage to a person if it's left untreated. Okay. Can you see this? Yep. So this is a very brief history map of bulimia. I think it has a very shorter history compared to anorexia. Anorexia was first discovered in 1689, but bulimia before 1970 was still reviewed primarily as a symptom of anorexia, until a British psychiatrist called Dr. Rochelle, he noticed in his clinic that a woman's symptom is the symptoms were very unique and not typical anorexia. So he later published a paper based on a series of 30 patients, and he defined bulimia as purging in response to overeating. However, at that time, this conclusion was objected by many scientists in the community because they pointing to his sample size, think it's problematic and it's too small. In 1980, bulimia finally made it to United States, and it became a diagnostic criteria in DSM V. So that's the first time that we do have a criteria for diagnosing bulimia. Right after 1980, the new cases of bulimia has spread from a few isolated cases to across the globe. It increased within a few years after 1980. If you're really interested, you can read some books about it. It was really fascinating. So DSM-3 revised version, the later version after DSM-3, finally listed bulimia as a separate eating disorder. Okay, so that was the first time that we do have bulimia nervosa listed as an eating disorder. Well, a lot of study has been focusing on identifying the prevalence, how many people, in the globe that has, really struggling with disorder. So one study, this is a survey in 2008, they discovered the lifetime prevalence is about 1.5 among women and 0.5 among men. In 2012, another survey that discovered a similar results. It thinks the lifetime prevalence is about 1.0%. The most recent review in 2023 think the rate of the prevalence are actually up to 3% in female and more than 1% in male. Research also shown, it's interesting, it's more prevalent among Latinos and of African Americans than non-Latino whites. And the mean age of onset is about 20.6 years old. And actually the median age means that most people will have this disorder around 18 years old. The research also says it's about 5 times more prevalent in cities than in rural areas. I think there must be a reason behind it. If you want to guess or you want to do more research on it, you will figure out. It's really fascinating. Like cities has more bulimia patients than rural areas. Well, the etiology is still unclear. I guess we still don't know what is really causing this condition. And plus, we know far less about genetic components of bulimia than anorexia, because anorexia has been studied longer. So, but we do know now is a very complex condition that arises from a combination of social, psychological, and genetic factors. We'll talk about each of these factors, okay? So the first one is genetic factors. Individuals with family members diagnosed with bulimia is 4 times more to develop a bulimia disorder at later life. And twin study has shown that the heritability is estimated for bulimia is to be 0.6. Just to give you an idea, heritability for autism is 70%. Heritability for schizophrenia is 75 to 80%, and heritability for bipolar disorder is about 70%. Okay. So research also shown that anorexia and bulimia are strongly genetically correlated. This is not surprising, but it's interesting that bulimic behaviors and alcohol misuse, they also genetically strongly correlated. But so far, the bad news is neither gene or genome-wide studies have identified any validated genes for bulimia. So what we can say is we don't really know which specific genes are causing it. What about social factors? Of course, gene doesn't act alone. For most of mental health disorders, social factors also play an important role. So for example, higher level of parents' education. You will think this is good, right? However, in research, it says higher level of parents' education, higher expectation towards children from parents, comments from parents on appearance or weight of their children, and siblings competition, they all risk factors for developing bulimia or any eating disorders. And peer relationship include being teased by friends, being bullied at school, having less friends, fewer friends, or social isolation, they always increase the risk of having bulimia. The last factor is the most interesting one. It's, right now we've been dealing with a lot of social media, internet, video games. This is our new generation has been exposed every day, all day long. Research has shown that even traditional media, including the current social media, they all have impact on, they all increase the risk of developing bulimia, having a negative impact on children's eating behavior. So I will talk to you a little bit more. Just look at these slides. On the top, you see a few images. They are from TikTok hashtag. I think you all know TikTok. The hashtag is called ThinsPo. It's an abbreviation of thin and inspiration. Basically, it refers to any internet content that related to unrealistic body goal, unhealthy eating habits, or even pro-eating disorder habits. TikTok has banned this hashtag a few years ago, and now redirect people who search it to eating disorder helpline. However, people can still find a way around it, and they still search it and able to use code word and discussing about eating disorder secretly. This is what our new generation has been doing. Some of them are really into this. And look at the traditional media. Okay, we have Disney princesses. I don't have any offense to any Disney, fans in this room, but have you ever thought about these princesses? They have such a small waist to hip ratio, like it's almost impossible to achieve naturally. So these messages and these images has been conveying some messages to our generations or younger generations. And research has always shown that teenagers are very vulnerable to messages on the internet. Therefore, for many of them, they cannot discriminate what they see and what is real. So I think this is what I really want to emphasize today. One of the slides I want to pinpoint. What about personal factors? I mean, if it's just the biological and social factors, it's probably not the whole picture. We have to take consideration the people, personal factors, the internal stage of a person. So research have shown that depression, anxiety, history of sexual abuse, and being under stress are all related to, bulimia. And certain personality traits can also increase a person's risk to have bulimia. For example, high level of perfectionism or rigidity, low self-esteem, and body dissatisfaction. The last one is the most interesting one. We have our grandchildren, our children playing sports, right? But the incidence of bulimia is much higher among participants of appearance-based sports, thinking about wrestling, gymnastics, figure skating, ballet, swimming, track and field. Okay, a lot of children who are doing this also suffering from the eating disorder. This is a very complicated slide. I'm not going into details, but I just want to show you. So these are the most recent research results from a neurobiological aspect of eating disorder, because researchers trying to figure out what is changed in our brain. And brain imaging study now allows us to study the living human brain. It helps us to develop more effective treatment. And they do find something. They figure out some consistent alteration of certain brain structure and alteration of brain reward pathways among bulimic patients. This probably tells us bulimia is not only a mental health disorder, it's probably also a biological disorder. Okay. Does anyone know this girl? Yeah, she's... Yeah. So we talked a lot about the etiology of bulimia. I just want to give you a real clinical case here. So in 1995, she disclosed to public in an interview at BBC that she has been battling with bulimia nervosa for years. She has multiple factors for developing bulimia. So here are all of them. First of all, she has a positive family history. Second, she has a dysfunctional marriage. She has isolation among royals. She had a lot of major changes in her life. These are all considered as environmental factors, right? Remember what we talked about? And she also disclosed in the interview that she has been depressed. She has low self-esteem, and she thinks she might have borderline personality disorder. This was also mentioned in Sally Smith's book. If you're interested, you can read it. And another book also mentioned the possible precipitating events for Diana's bulimia is probably a few weeks after engagement. Her husband put his hands on her waist and commented, said, "It's a little choppy." So that's everything got started at that time. It was really a sad story, but I think everybody knows her. It's better to use her as an example. So what are the criteria? It's not that complicated. If looking at these slides, you probably will be intimidated, but it's just 4 components. Number 1, recurrent episodes of binge eating. Okay. Number 2, recurrent inappropriate compensatory behaviors. Number 3, the binge eating and inappropriate compensatory behavior should both occur on average at least once a week for 3 months. Okay. Last one, all these behavior changes should be stimulus driven. Okay. So this basically is the DSM V criteria. When we seeing a patient, we use this to diagnose. Compensatory behaviors are hallmarks for bulimia. I don't know how much of you are familiar with compensatory behaviors. Have you heard about this term? No? Which is a good thing.
Give us a little background on what that means.
Compensatory behaviors means that a person, like what Dr. Rochelle mentioned in his paper, is a person using a way to relieve the guilt of eating. Okay, anything they do to relieve the guilt of eating. It has 2 major categories. One is purging, the other is non-purging. Self-induced vomiting is the most common one. Okay, but it's not the only one type of purging. There are also other types of purging. For example, misuse of laxatives, misuse of diuretics, enemas. Okay, and the other category of compensatory behavior is called non-purging, including fasting, restricting, exercising. And it's very interesting. Some of the patients, they will chew on their food and then spit it out. And research has shown that about 25% of patients with eating disorder will do this. It's called chew and spit. Sadly, if a person has this type of symptoms, it usually means that the person has more severe type of eating disorder. Okay. This is more like when we make a diagnosis, we want to know the severity, right? So the severity of eating disorder or bulimia is based on the number of purging episodes during a given week. Okay, so if it's between 1 to 3, it's considered as mild. If it's 4 to 7, it's moderate. 8 to 13, it's considered as severe. If it's 14 or more, it constitutes severe bulimia. Okay, and if a person is recovering, how do we define it? Do we say this person never had bulimia? No, we say the person had bulimia diagnosis, but is currently in partial remission. Okay, if a person is completely recovered for a certain period of time, we will say this person is in full remission, but had a diagnosis of bulimia. Okay. DSM V dropped the subtyping of bulimia, so it's simple now. It's just one diagnosis, bulimia, no subtyping. It's really good news for the clinicians. Well, now we know a little bit more about bulimia, but how do we differentiate from bulimia between bulimia and other eating disorders, and even other mental health disorders? So anorexia is very similar as bulimia. Okay, remember we talked about it. They are siblings, and they have a lot of similarities. However, it's very important to differentiate them. You don't want to confuse by these two disorders. You don't want to make a wrong diagnosis. Don't want to mix it up at all, because their complications, prognosis, their management are very, very different. Okay, so this is what I think will be useful for differentiation diagnosis. So for anorexia, most people will have a lower body weight, okay, specifically BMI less than 18. However, it's not a criterion for diagnosing bulimia, okay? That's number one. If a person only binge and purge during episodes of anorexia, the person only given one diagnosis of anorexia with the subtyping called binge and purge type, the person will not given an additional diagnosis of bulimia. So basically, one person only carry one eating disorder at one certain period of time. This is getting more complicated now. What is atypical anorexia? What is it? So this is a very interesting clinical scenario. Some patients, they have a normal weight. Sometimes they overweight, but they meet all criteria that anorexia has except for being underweight. How possible, right? So here's a growth chart. On the left, that's left. On the left, you see a typical growth chart among patients with anorexia. You see the drop, right? It already below the normal range of body weight. On the right side, an individual at the end of certain months or age, the person still maintain a normal body weight, right? However, there's a sudden and dramatic drop in the weight loss, right? So this person is considered to be diagnosed atypical anorexia, okay? So the way that you differentiate between bulimia versus atypical anorexia, it cannot be based on weight anymore. So this is how you do it. When you see a person that has a normal weight but has all the criteria, meet all the criteria for anorexia, and the person had a sudden weight loss, that means the person has atypical anorexia instead of bulimia, okay? It can be even more complicated in clinical setting, but this is just the best I can do. For binge eating disorder, we talked a little bit about it. It means a person that eating a large amount of food in a very short period of time while not being hungry, remember? So how do you differentiate between binge eating and bulimia? This is a little bit simple, You just tell by the purging behavior, whether it present or not present. If you're not seeing the purging, it's probably just binging eating disorder. Another key point is binge eating disorder, people don't restrict even between binging episodes. But bulimia, people do restrict between episodes in order to keep a normal body weight, okay? Major depressive disorder is pretty common. I think most of you probably have heard about it. Overeating is very common, right? Especially among people with a typical feature major depressive disorder. It means that the person will eat more under stress when it's depressed. However, people with major depressive disorder, even they overeat, they don't have compensatory behaviors. They don't purge, and they don't overly concern about their body weight or shape. Okay, so this is the way you differentiate. And I apologize for my typos. Keep that in mind. It can really co-occur. Depression and bulimia or all other eating disorders, they sometimes go hands by hands. When we encounter a patient, how do we evaluate? The first thing I have to say, Clinicians need to make prioritization in terms of determining the level of care, because you need to know if your patient needs acute medical stabilization. What are the factors that will, make you think about acute medical hospitalization? Fluids management, supplements, especially if it has to through NG tube, we call it nasal gastric tube. If the patient needs electrolyte supplements or replacements, if the patient needs close monitoring, these people need to go to inpatient unit right away, okay? Factors that will need, will suggest the inpatient psychiatric treatment: suicidal risk, aggressive behaviors, impaired safety due to psychosis or self-harm, involuntary treatment, because you have to know a lot of people don't really want to receive treatment, especially talking about eating disorders, co-occurring mental health conditions, or lack of response or deterioration in outpatient treating setting, okay? The good news is most people with bulimia can be safely treated outside of the hospital, okay? Very rare cases that they will need inpatient treatment. After determining the level of care, we will need to move on to gather more information, okay? We want to know a little bit more about the history so we can formulate our treatment plan. We need to know mental health history, we need to know social history, and by social I mean drug use history, family dynamics. We need to know family psychiatric history. We need to know physical history, medical history, previous current medications. We need to know menstruation history for female patients. A review of system is also important because we want to rule out all other possible mental health disorders. Okay, so we'll ask a lot of questions for the first encounter. A complete physical exam is important because, as I just said, bulimia is a mental health disorder, but a lot of times it can cause a lot of medical conditions. So we do need a physical exam. We need to obtain weight, height, blood pressure. We need to check skin, mouth, abdomen. We need to do a neurological exam to rule out possible reasons, neurological reasons for weight loss and vomiting. If a person has purging behavior, we also need to refer the person for a complete dental exam. I will tell you more later. We also need other labs. Okay. Some are really routine lab tests, including comprehensive metabolic panel, complete blood count with differential, vitamin B12, urine analysis. Based on the results of the physical exam, sometimes we also need other serum magnesium level and serum phosphorus level. Sometimes we even need other EKG, but these are not always unnecessary if the physical exam is, have no concerns. Pregnancy test, of course, needed for female patients, and testing for sexual hormones is important if a patient has amenorrhea. We just want to rule out any other medical reasons that can cause amenorrhea. We will talk a little bit more about the lab abnormalities, okay? But these are the most common ones that can be associated with bulimia. A lot of disorders, disorder lab values you will see in patients with bulimia. So what about why this is important? If it can be treated outside of the hospital, if we can identify it, we learn how to identify it, why this is still important. I think the really sad news is it often co-occur with other mental health disorders. So make it really, really complicated to be treated. This is a research from from a survey. I don't remember the year, I'm sorry. But this was a research from a survey. It shows about 94% of patients with bulimia also had a lifetime history of at least one additional psychiatric disorder. What does it tell you? 70% of patients with bulimia have depression. 26% has generalized anxiety disorder. 61% has alcohol use disorder. Thinking about the genetic correlation we just brought up before in previous slides. And 43% struggles with nicotine use disorder. 30% struggles with all other drug use disorders. 32% has a PTSD. 17% has premenstrual dysphoric disorder. 60% has impulse control disorder. This is a very common thing that we see in clinic. I think most of people probably know borderline personality disorder. Do you know? Or you need more explanations about this? It's one type of personality disorder, and it's very detrimental, and it can impact the person's whole life and cause a lot of peer relationship issues, mood dysregulation issues, career issues. So this is a very detrimental personality disorder. Research has shown that there's a link between bulimia and borderline personality disorder. Remember Diana, she had both. We don't know why, but we just know about 48% of the cases also, bulimia patient also has borderline personality disorder. There are a few behavioral or personality traits that they share together. Number 1, attachment disturbance. Number 2, adverse child experiences. And then non-suicidal self-injuries. For example, self-harm by cutting, burning self or torturing self. Interpersonal difficulties. And they both have disordered mood and impulse dysregulation. Okay. We have talked a lot about possible comorbidities mental health-wise with bulimia, but what about medical complications? It's not better than mental health complications. So unlike anorexia, most complications will arise from weight loss or malnutrition. For bulimia, the medical complications arise from either binge eating or purging. So, for example, complications related to binge eating will be, gastric rupture, nausea, constant pain and distension in abdomen, prolonged digestion, weight gain, and complications associated with purging is even more complicated, and it gets involved in many organ systems. For example, from head to toe. Patients with bulimia, if they do have purging behavior, they will have enlarged salivary gland, and their teeth will be eroded by gastric acid or wash their mouths when they purge. And they also have a higher risk of developing, GERD. It can eventually lead to increase the risk of esophageal cancer in the future. And it can also cause a rupture of esophagus, which is a acute, emergency medical situation. When they vomit, it's a big power from inside to outside. Sometimes the enforced vomiting can cause rupture of the esophagus. There are also a few isolated cases, have draw some connections between bulimia purging to acute pancreatitis, but it has not been well studied yet. Of course, purging can also relate to electrolyte imbalance. For example, hypokalemia. Hypokalemia can cause arrhythmia, means their heart will start to beat irregular. Research has shown that cardiac arrest means heart stop beeping, right? Among patients with bulimia and purging behaviors is 20 times higher than general population. And the problem is periodic lab testing will not detect this subtle electrolyte imbalance. So this will happen without knowing it. Another survey, a WHO survey in 2013, it's looking into long-term complications of bulimia. They discovered that the patients with bulimia has a higher risk of having arthritis, chronic neck and back pain, diabetes, hypertension, ulcers, subsequent heart attack, and stroke. So this is not just a short-term damage or at that moment damage, it's more a long-term and permanent damage. Because, we have to talk about this. This is very heavy. Bulimia has a strong connection with suicide, okay? It's even higher than restrictive anorexia. So eating disorder has the second highest mortality rate among all mental health disorders after opioid use disorder. So it's the second highest mortality rate. And bulimia has the second highest increased risk of suicide following another type called anorexia, purging, and binging type. Okay. The prevalence of suicidal attempt is estimated to be 31.4% for bulimia. So other research have shown that about 5% of patients with bulimia had a history of suicide attempt, and non-suicidal self-injury rate is between 26% to 55% for bulimia patients. This is what our primary care dealing with every day. They're very busy. You've been to primary care office, you know how many patients they see and how many minutes they allow to see you. Approximately, this is very conservative estimation. Half of all eating disorder cases go undetected in primary care. Well, the reasons are many, but I think it can be related to time restraints and providers not knowing what to do with concerning results. But I think it's important for primary care to know, research has shown that early detection and prompt intervention can prevent as many as 2/3 of patients from developing a more severe eating disorder. Okay. Well, how can we treat it? So now we get to the meat. So what do we use in clinic to treat patients with bulimia? So most of these are what we use, but the best ones are the ones has the most evidence are psychotherapy and pharmacological intervention. There's a logic here, there's a order here. So the first line, you will always want to consider a combination of pharmacotherapy plus psychotherapy. They are proven to be the most effective way in treating patients with eating disorder and bulimia. The second line, if you want to go down, will be psychotherapy alone. It's not drugs alone, right? And then the third one has, some evidence is medications alone. Then you probably want to ask, why when I go to a doctor's office, a psychiatrist's office, I always get meds, no psychotherapy? The answer can be a lot, but I think medication is reasonable when psychotherapy is not accessible, okay? Or when psychotherapy is not going to achieve the same or the adequate effect. So it's considerable, but it's not the best, specifically for treating bulimia. Psychotherapy alone is superior than medication alone, okay? If we have to use meds only, they will encourage clinicians to encourage their patients to use self-help workbook or educational materials at least, not just medication alone. Okay. Just a little bit more about psychotherapy, and we'll talk about medication choices. So the golden standard treatment for bulimia is a type of therapy called cognitive behavioral therapy specific for eating disorder. That's why it has a -ed. It's the most effective approach. It has been proven by many research. It can reduce binge eating, vomiting, reduce symptoms, and it has even a long-term effect. However, it's very hard to get this type of therapy because you need special training. Not all therapists can do this. But at least we know this is the golden standard treatment. Interpersonal psychotherapy is another type of therapy, has similar effect, but takes longer to get to the same effect as CBT. So CBT can be faster than interpersonal psychotherapy. Mindfulness-based intervention studied some evidence, but not very well studied yet. So I cannot say anything about it. Exposure therapy is interesting. It was first designed as using patients with obsessive compulsive disorder, but they sort of, changed this method and fitting into treating bulimia. They use food intake as conditional stimuli and trying to extinguish the bond between food and maladaptive binge response through gradual systematic exposure. So this has some evidence as well, might be a alternative way to treat bulimia. Dialectic behavior therapy. If you draw a connection, you probably will think about borderline personality disorder right away because this is the golden standard treatment for borderline personality disorder. However, it only have very preliminary promise for treating bulimia, and it's not well studied yet. Okay. What are the medication choices? This is my thing. I do this every day. So the good news is there are a lot of treatment, and there is one FDA-approved medication that is indicated for treating bulimia. The medication is called fluoxetine. You probably heard about this name before. It's also antidepressant and anxiety medication. We use it for many other mental health concerns as well. But this is the only FDA-approved medications for treating bulimia. There are also other medications like citalopram, sertraline. They're also on the list of medications, but they are not FDA-approved. All other antidepressants, when talking about other SSRIs, they are not considered as first line. So the 3 first-line medication will be fluoxetine, citalopram, and sertraline. However, citalopram has a problem. When you take higher dose of citalopram, sometimes it can cause prolonged QTc interval. What does it mean? It means that your heart is going to beat irregular. Remember what we said about bulimia. So it has a big concern of using citalopram. So maybe if you want to be conservative, sertraline and fluoxetine will be probably your choice. When you use fluoxetine, you need to remember for treating bulimia, you need to use it at high dose. It's a very high dose that they don't typically using among patients with depression, and you need fast titration, like you go from 0 to a high dose in a few days or no more than a few weeks. Okay, this is the most effective way to treat bulimia. It's a little bit special. A few small uncontrolled studies means the quality of the study are not as good as randomized clinical trial. They suggested that mood stabilizer, for example, lamotrigine, also called lamictal, could also be beneficial in controlling bulimia behaviors. Okay, and another medication, antidepressant, most of the time used as a sleeping meds, trazodone. I think you probably heard about it. Trazodone mostly used for, sleeping, although it's antidepressant. But research has shown that it can reduce frequency of binge eating episodes when it's used at very, very high dose. And this high amount of dosage really limit its use because it can cause sedation. It can cause low blood pressure. So this is probably not the best choice either. Well, the other two, you see very weird letters here, MAOI, monoamine oxidase inhibitor, and tricyclic. They are reserved as last line, like last resort for treatment-resistant cases because they themselves carry very bad side effects as well. We don't want to make the medical situation more complicated. Bupropion is probably not familiar, but Wellbutrin you probably heard. Wellbutrin is contradicted in treating eating disorders, especially anorexia and bulimia, because it can increase the risk of seizures among epileptic patients. So this is absolutely no. Stimulants, the study only been conducting among patients with both ADHD and bulimia, so it's not a very good study at this time to tell us whether this is going to be a choice for patients only has bulimia without ADHD. So we don't know that yet. Well, that's a lot about medications. Now let's talk about what is going to happen after. Research has shown the persistence is about 6.5 years. Means that 75% of the patients will recover in 5 years. However, 47% of them will have a relapse within 5 years. So this is a good news and also a bad news, right? And it's interesting, the pattern and the timing of the remission or relapse of bulimia has nothing to do with severity of the symptoms, has nothing to do with personality disorder, psychopathology. Okay? A meta-analysis, a very big, large data set analysis showed bulimia is associated with increase in all-cause mortality at relative risk of 2.11. What does it mean? It means that people with bulimia will probably die 2 times more than general population. Okay, and another study of a long-term follow-up study, it showed that 1/3 of those with anorexia, the restrictive type of eating disorder, they will come across over to bulimia. Means that although they were not diagnosed to eating disorder diagnosis at that time, but they can come across to each other at a certain time. And about 14% of those with bulimia cross over to anorexia. Okay, because I am a child psychiatrist, so this is what I am interested. So I did some research looking into bulimia in adolescents. It was very surprising. Average onset of binge eating is 16 years old. And a study in Finland among 9,000 adolescents aged from 14 to 16 detected a prevalence of 1.8 in girls and 0.3 in boys. And another study in here, South Carolina, among 3,000 middle school students, found that 42% of girls endorsed a history of dieting, and 5.6% have vomited specifically to lose weight. What's the pattern of bulimia? Typically, it started with dieting, okay? And then subsequently, it will goes into binging. And then it will trigger purging or other compensatory behaviors. So this is the pattern how it developed, okay? What about the symptoms of bulimia in adolescents? They can be different compared to what the adults have. First of all, adolescents have greater denial. They have less desire for help. So you probably won't know unless you find out something. They will not tell you and they don't want any help from you. Second, their symptoms most of the time doesn't really meet a full criteria for certain eating disorders. Means that it's easily to get undetected or overlooked because it doesn't meet full criteria. So this could be a problem. And the third difference is even more sad because it can cause more suicidal ideations among children compared to adults. About 55% endorsed suicidal ideation among this population in adolescents, and over 25% had a plan. More than a third had a prior attempt, and 17% had multiple attempts in the past. So what are the risk factors? As a parent, as a grandparent, what should we do? So these are all the risk factors. From a developmental perspective, body dissatisfaction can generally be seen in girls as young as 5 years old. Okay? And it peaks during adolescence and remain constant throughout a woman's 20s. I mean, if you pass 30s, you're probably safe. That's how I see it. So what environmental factors can have an impact on children's, eating habits? History of child sexual abuse has a strong link with bulimia or other eating disorders. Young people are more prone to be influenced by social media. We already talked about this. Peer pressure, bullying, teasing, feeling of not being good enough, these are all risk factors. What about the family? Well, there's something to do with parenting style. Unsatisfactory parental bonding, maternal invasion of privacy, maternal jealousy and competition, families over concerns with children's weight, shape, and eating. They're all possible affecting, the eating habits of your children. And it has been more consistent predictors, diagnosis of bulimia has been a more consistent predictors of dysfunctional family dynamic compared to all other eating disorders. This is a very special treatment for children with eating disorder or bulimia. Everything else we discussed may apply to children as well, but this one is something special. It's called family-based therapy, and it's a mainstream in treatment of children and adolescents with eating disorder, and has very good effect. It can, help the parents, help the family, and help the children. You have to make sure you differentiate it from a traditional family therapy. They have similar name, but they are not necessarily the same. This is family-based therapy, and it's focusing on empower parents to participate in treatment plan instead of blaming parents for what they do. So this has been more effective than traditional family therapy. Bad news. I always have bad news. This is not really applicable in outpatient setting because it requires very intensive visits. So most of the time, you can only see it or have it during, partial hospitalization programs or residential. So this is a disadvantage. There are 3 components of this program. First, weight restoration, that goes in orders. Second, restoring control of eating. Second, returning of normal adolescent's developmental life. family meals will be the main thing that they discuss in the sessions. It's the core of the treatment. Typically, 3 meals plus 2 or 3 snacks. So if you had your snacks today, it's, under 3 or 2. This is also important. It's not part of the treatment, but I personally think this is a very important piece. Because when a family come to you, you want to give them as much education as possible. Okay, so education, number 1. Parents should never be a bad role model. Do not discuss or advocate diets or meal skipping. Okay, rule number 2. Educate your children or grandchildren, know good foods and know bad foods, okay? Family should always eat together, okay? Avoid comments or compliments on person's appearance. Your children's appearance, no. Your children's weight, probably no. You want to make compliments on their efforts, attitudes, behaviors, personalities, okay? Avoid discussing guilt-induced exercise, and do not complain about parents' own weight in front of your children. It's very hard to do, but it's very easy to say, right? This is a summary. If you don't remember most of what I said today, it's okay. Just remember this on the last slide. So the key point is bulimia is still, etiology is still a puzzle. We don't know, but we know it's a combination of social, psychological, and genetic factors, okay? And we also learned it can cause very severe medical complications, okay? Mostly due to PERS, okay? CBT, specific for eating disorder, and fluoxetine are evidence-based treatment, okay? For children, family-based therapy is more effective, okay? Psychotherapy, psychoeducation, and multidisciplinary treatment team is necessary, including mental health professionals, medical team, nutrition, rehabilitation, school. Don't forget school. All parties need to play, a very important role in treatment. This will be, a successful treatment for our patients. I think that's all for my today's slides. Thank you for your attention.